Have you ever wondered if that new weight loss pill is actually worth it or if it's just marketing dressed up as medicine? Since launching, the new oral GLP-1 has had surprisingly few takers, and once you hear why, you'll understand. I'm Dr. Kate D, and this is Medspa Confidential. We expose the risks, the red flags, and the outright illegal practices happening inside med spas right now, because you deserve to know the truth before you book. Today, I sit down with Dr. Randi Lindstrom, a GLP-1 prescriber with real clinical experience helping patients navigate weight loss and everything that comes after. You'll find out why the new Ozempic pill has some serious drawbacks. A major new study just revealed what actually happens to your body when you stop taking these drugs, and the cancer connection that's just starting to come out of the research. And it's a big deal. Stay until the end because Dr. Lindstrom reveals what's happening with fertility on these drugs, and it's not what most women expect. What she shares today could change how you think about weight loss drugs entirely. Hi, I'm Dr. Kate D, and I'm back today with Dr. Randi Lindstrom. So, Randi, can you talk a little bit about the pill, and is it good, is it bad, and why you think you will or will not be prescribing this pill?
Yeah, I think this has been a lot of excitement about getting like an oral option for people to come out. We knew that this was starting to get approved in November timeline, and here we are. You've got oral Wegovy or oral semaglutide. It's kind of an interesting segue. I think like it maybe has its place. I don't think we're there yet. And so a couple things to kind of like know about it, right? So it's a daily pill instead of a weekly injection. With this, it's still the GLP-1, but if kind of everybody remembers, like a GLP-1 is basically a string of amino acids or peptides, which is, essentially meat. So your stomach is really going to just going to digest it as a piece of meat unless you have a specific molecule to help it be absorbed. And I think this is where their challenge has been, is why it's traditionally been an injectable and not an oral, and it has taken some time to get here.
A recap for our listeners and people watching, because we've talked about this before, this is why other kinds of proteins like collagen and stuff, when you eat them, they just get digested. They don't get absorbed whole. So they don't really have the effect of administering that same protein in a different way. And so, yeah, we have been using it as an injectable because it just kind of doesn't get absorbed right when you eat it. Okay, so to the pill, how did they fix that pill so that we actually can eat the pill and it still does something?
Yeah, so it's kind of like it's called the snack model, but it's basically something that they've had to put onto the GLP-1 that then helps affect the pH and then helps it be absorbed through the stomach in a whole molecule, because you need it to stay as complete as a chemical property for then it to act in your system as a GLP-1 and not be broken down. And so this is why it's taken some time to do it, because they also then had to study and see what is the efficacy. They kind of tested it in the blood when you take an injectable at, 2.5 milligrams of tirzepatide. What is that equal to for like a blood response with the semaglutide in your blood? Like how well is it absorbed? And so They have this special molecule attached to it. And then it's also affected by like the pH and your stomach and all kinds of other things. So the interesting other component to this oral medication, in addition to it now being daily, is that because it has a finicky rate of absorption, you have to like be very careful how you take it. So it has to be like on a completely empty stomach, fasted. So usually that's going to be first thing in the morning. And you can only have like a sip of water. It's like 4 ounces of water. And then it has to be at least 30 minutes after that. So now you've complicated your day. It has to be very structured.
If you have more water, what happens to the drug?
It potentially sort of dilutes the air, or like the pH of the stomach. And so it's not going to be absorbed as much. So like thyroid medication, I think you can have like a lot more water, but they're saying 4 ounces of water.
Okay. So there's not very much. And then for somebody on something like thyroid, which is so common, I've been on it for most of my whole life. So you take it first thing in the morning and you're supposed to wait at least half an hour before you eat. Now, if we're taking this pill, you'd have to do the thyroid, wait half an hour, and then do this pill and wait another half an hour?
or you have to like transition to your thyroid medication in the evening and then readjust your dosing, because
Right, you can't really do that.
but like now you're messing with both the thyroid absorption because that has a finicky absorption rate, and now this
Yeah.
oral semaglutide. So so it becomes a little bit more challenging. But if you're having to do that daily, you got to make some other lifestyle changes. And then, and then the other thing in the head-to-head studies, like it does have, because it's going through the GI tract, seems to have a little bit more of those GI side effects. So we know the GLP-1s have like some nausea, vomiting, acid reflux. Now we're in the stomach itself, trying to absorb, and we're having increase of those side effects. So people who maybe have had zero complications, zero side effects, and want to switch to the oral, then maybe good. But if you're already having some nausea, this is potentially going to make it worse.
Right. And as far as I know, there isn't a tirzepatide pill yet, the
Correct.
Zepbound pill. So for a lot of people, they've gone to tirzepatide because semaglutide gave them too many symptoms. This pill is definitely not for them, right?
Yeah. I mean, I do think everybody's individualized, and maybe there's some other benefits if people are really like needle phobic or something like that, and they're having a hard time giving it at home, then maybe, right, for compliance issues. But
have you had anyone like that so far?
I had somebody who was not giving it at home, or coming in and needing, someone to specifically inject for them on a weekly basis, just could not do it themselves. So,
They just can't
but
do
I think
it.
it's more rare. I think most people like can get comfortable with it with proper education and teaching. So, but yeah.
Okay.
Oh, the next thing I was going to say about the oral pill is also like there's a little bit decreased percentage of weight loss. So it's not crazy, but there is, in the study so far, it is showing that it's not exactly as effective as the injectable semaglutide.
Interestingly, from like my own personal point of view, I just feel like I've said this before on the podcast, that I think that tirzepatide's a better drug, fewer side effects, more weight loss. So this pill being even more side effects than semaglutide and not as much weight loss, although that sounds like not that big a difference. So my vote would be no, unless you absolutely had a reason why you couldn't get the injectable.
Yeah.
Is it much cheaper? Is the pill cheaper at all?
So that's the interesting thing too, right? Is like there was kind of this whole big thing, and sort of politics aside, President Trump kind of made a big splash that he was going to make this more affordable for the general Americans. And what they've chosen to do is make their starting dose, only $149. But the problem with their starting dose is that it is only like 1.5 milligrams. And this comes into play. You're like, oh, well, we go up to 2.4 for injectables. The problem is the conversion on this is that you about need 10 times as much medication for it to be effective. So you're looking at someone who's on like the 2.4 milligram injection needs 25 milligrams of oral semaglutide daily for it to be like equivalent. And those prices are not $150 a month. And right now, insurance companies have still not sort of gotten on board to reimburse the oral. This is all cash at this point. And, I think maybe it'll get there, but right now the starting dose at the potentially cost effective is really not even a therapeutic dose. It would be very much like a micro dose.
Okay. So basically not less expensive, not as effective, more side effects. But you don't need a shot.
And tricky dosing daily. You have to
My guess also is with people's bodies, their absorption is probably more variable, right? I mean, is it that like I could take a pill and absorb less than you could? Like, how consistent is that? Do we know?
And, I mean, that part, I don't think the studies really show that exactly. They're trying to do it, equivalency in the blood, and they're trying to control for all the variables. But, again, you've taken thyroid medication, and it probably took some time to get to your this dosing gets you like this level in your blood. And we don't really have tests to say, here's your GLP level in your blood to show that you've effectively gotten that for the average, person. They're doing it in these studies, but they're not, it's not somebody can go in and test and make sure you're hitting your therapeutic level. So it's going to be a little bit unknown.
The absorption is different with thyroid, is very different. So that's why people's doses are so different. And then even when you switch manufacturers, your levels can change and your dosage can change just because you change generic manufacturers. That's really common with thyroid. So that's just kind of normal physiology. So basically, this is interesting, maybe the right solution for a small number of people. But to me, it sounds like it's not really like, no, people aren't going to jump on this bandwagon.
I don't think so. It was kind of interesting. The first week came out, like, I think they only sold 4,000, which would be, if you think about that across, the United States, that's a pretty low number. You expected more to be 20,000. I think it's just for all of these reasons, and it's just, and then also if you're, there's no real studies on transitioning somebody. So somebody is already on, the tirzepatide or semaglutide injectable, and then they want to move to the oral, how to do it. We kind of know it's 10 times dosing, but are you just going to jump from somebody at the 2.4 injectable to 25 milligrams? Are you going to make them sick? And there's just a lot of that type of stuff. So this may be somebody that you could start on the low dose who's never taken any of these medications before and kind of see where they go. So
how they do, if they tolerate it okay.
Because people are only been doing it for a couple of weeks now. It's not like this is
it's brand new.
Yeah,
it's brand new. So we will have updates as we get more information. I do want to update everybody on a couple of other pressing questions because these drugs have been around now for several years, and lots of people have questions about what happens long term. Do you keep the weight off? Are there other benefits or even risks of being on this medication? So can we talk about, there was a recent study that talked about whether people keep the weight off if they need to keep on maintenance?
Yeah. So I think that the study is the SURMOUNT-4 Regain. And I think important notes of this, that the study included people who had a BMI greater than 30 or a BMI greater than 27, but had one other obesity or insulin resistant disease process. So diabetes, something along those lines, right? This study looked at people specifically on tirzepatide for 36 weeks. So the people had to be on the tirzepatide for 36 weeks, meeting those other categories. And those people also had to have a response to the tirzepatide and low side effects. So those average people lost 21% of their body weight. Then,
amazing.
Yeah, exactly. Amazing. Then they split it into two groups. Then they continued half those people on a placebo up to 52 weeks, or they continued on the tirzepatide.
I was going to ask you how frequently, if they were continued on it, are they doing it still weekly or are they cutting back to more of a maintenance cadence? So if you've been listening to the show, you know I've got stories for days about what goes on in med spas. I finally put them all in a book. It's called Medspa Mayhem. I wrote it because I got tired of hearing about people getting hurt by providers who have no business holding a syringe. You'll read about real patients, real nightmares, but more importantly, you'll know exactly what to look for when you walk into any med spa and what questions to ask. It's part expose, part survival guide, and it might just save your life. Medspa Mayhem will leave you informed, entertained, and a little shocked at what's really going on behind the business of the aesthetics industry. The link is in the episode description. Read it before you book your next appointment, because beauty should never come at the cost of your safety.
The way that they considered maintenance was a weekly continuation. So those people continued to lose weight, another 5.5% of body weight loss for that group of people. And so, but then the interesting thing about this, right? So everybody wants to know, do I have to be on this medication for life? Am I going to have rebound weight gain if I come off of this? And the study did show that there is a chunk of people that did, have rebound weight gain. So there's about 33% of the people who were on the placebo that gained back 50 to 75%. So that's a big, not all of it, but that's a big gain back.
Yeah. Over 1 year.
So from the 36 weeks to the 52 weeks. The interesting thing was that there is 17% of these people who I would classify as people who have a disease of obesity, which is the metabolic syndrome and stuff like that, that actually can maintained or lost weight, continue to lose weight. So it's not really a one size fits all. I think that's sort of what it tells you. There's an interesting, in their study themselves, they have a waterfall plot, which actually shows you sort of what each person in the study is doing. And there was 4% of the people that continued to actively lose weight. So that tells me that those people really with their disease of obesity, maybe they haven't been doing it, maybe they haven't been as obese as long or something along those lines. And they really just needed like a jump start, a kickstart. And then they were able to kind of continue that active weight loss. So there's 17% that had no rebound weight gain. And then there was 4% that actually had continued weight loss even after stopping it. So that's really interesting to me. And it just kind of shows, I think, that this is really like individualized by the person, how your like metabolism, your genes respond to this. It's not going to be just one person, and really should be looked at by case person.
So of the people who went off of it completely, it was 33% gained weight?
Gained up to 50 to 75% back of their weight loss.
Okay.
So if they lost 20%, then they gained back,
okay,
10%.
So a third gained a lot back, but not all. And then how many gained weight, but not much, or maintained? Or I didn't.
So 17% maintained. And then there was a portion of people, there is like 20-ish% of people that did gain back like over 75% of their weight. So they gained back everything, basically.
Okay. That's where the missing piece was for me.
Yes,
okay.
sorry.
So a fair number, so if you're off of it completely, it's only about 20 or 25% that keep it off without maintenance.
Well, yeah, in this study, and people who I would classify who have like a disease of obesity, which is, usually like a chronic state.
Yeah.
So it's kind of interesting for people who are maybe not using it, who don't have a BMI over 30 or using it for other reasons, or looking to lose a smaller amount of weight, what that means for them. I do think that
right,
kind of what's out there and everyone's kind of talking about it, I think we all sort of agree that just stopping it cold turkey is really not the way to do it. This study shows that some people do still do okay even if you stop a cold turkey, but most of us would say it needs to be like a titration, a weaning, kind of looking at the individual person and deciding what's best for them.
And most of us physicians anyway, who've had experience prescribing this for patients, we consider maintenance more of a backing off, not necessarily of dose, but of interval. So, some people 4 weeks, some people 3 weeks, some people 2 weeks, just you're taking it less often. And I know that for me, that has worked for me. So I lost weight on the lowest dose of tirzepatide, so 2.5, which again is not really considered a treatment dose, but that's what worked for me. And then now I'm doing it every 3 weeks or so. And so that has worked for me. I've been completely stable for like a year now on that, but everybody's different. So how do you decide? I think you just work with your patients and figure out what works for them and try to ease them off of it, but keep the weight stable.
Yeah, I think so. And then it also depends on like a lot of different reasons of why they're taking it. I've had like a variety of clients have like other benefits, like they feel like it controls some of their ADHD symptoms, or just they're able to think more clearly because, that food noise has gone away that so many people talk about. And so even though they've achieved their weight loss goal, they really just want like a low dose in their system for some of the other benefits. And so we kind of look at that. I'm really careful. Like we don't want to lose some of those people who respond really well. Or just have to be careful because they like some of the other benefits, but then they continue to lose weight on like really low doses. And that's really not what it's about at that point. And so it's really trying to titrate and work with them individually on like, their, resistance training, they're eating enough food and calories, and they're using it for some of the other benefits that they, for their lifestyle.
Let's move on to a couple of other long-term things regarding being on GLP-1s. And I know that before we had mentioned its effects on cancer. So can you talk about that?
There's a lot of studies coming out, and we're going to have even more coming out in the next 5 to 10 years as we're seeing all these benefits. But they're showing a decreased risk in 13 types of obesity-related cancer. So these are cancers like postmenopausal breast cancer, colorectal, pancreatic cancer, esophageal cancer that are kind of linked to obesity. And the reason why these particular cancers are linked to obesity has chronic inflammation. They're increasing your hormones with like insulin-like growth factors, your sex hormone, metabolic dysregulation. This kind of all contributes to some of these cancers that are related to obesity. So they're seeing that obviously if you can like reduce the obesity, you're going to reduce these cancer risks and that they already are associated. But some of the interesting information coming out, and these are all observational studies, so of note, right? We need long-term studies, but so these are not the controlled regulated studies. Why am I losing my words here?
Randomized controlled trials.
Thank you. Randomized controlled trials. These are observational, but they're showing that there is like a reduced risk of recurrence, which means like that the cancers come back after you beat it. If they are on the GLP-1s with lowering their obesity, and also that the risk of death related to these cancers while they're on GLP-1s has been reduced. So whether this is just related to the obesity itself or versus the GLP-1 signaling, that's where it's starting to get interesting. So there is some like indicators that this may be related to the GLP-1 receptors itself, because we already have stuff like insulin and metformin and things that kind of work on insulin sensitivity, right? And the GLP-1s seem to be working in a different signal from that. So there's some interesting studies in the works from that, but I think like that's a big deal when you're talking about 13 different types of cancer, and that this is potentially reducing the risk of getting it, the risk of recurrence, and the risk of death if you get these cancers by reducing your obesity and potentially the GLP-1s themselves.
I would think also that it would reduce the incidence of all the disease related to diabetes and obesity, like renal disease, peripheral vascular disease, heart disease. I mean, are we seeing that as well?
Oh, yes, 100%. Like we definitely know that, like in the metabolic syndrome, right, that increases your cardiovascular risk. We know that like your visceral fat level that's on and around your organs, that increases your risk for strokes and heart attacks. And so if you can reduce that in and of itself, that you're going to be reducing your heart attack stroke risk. Interestingly enough, and I kind of have to point this out, that if you do have the rebound weight gain, some of those factors, lose their effect. So meaning like a lot of people, like their blood pressure will go down on a GLP-1, and then if they come off of it, their blood pressure will rebound, on it. So it seems to be, just while on the medication. But like I said, interesting to see where these studies are going to go. I know that they're doing a lot of research in cancer to see if these are intrinsically reduce the risk versus just reducing the obesity component related to these cancers.
All right. And any other long-term issues you'd like to bring up related to being on these drugs for a longer time?
Yeah, I think that the other two things that I kind of like seen a lot of, and I actually have some, patients that have kind of worked with them in this regard, is arthritis. We know that like the GLP-1s are decreasing the inflammatory components like CRP and CAM and sort of your immune response. So we're seeing a reduction in like arthritis and autoimmune components. And then also there's some like new studies coming out for fertility. I think that's another big deal for people who are struggling with infertility. We know PCOS can be a high indicator for infertility along with like fibroids and endometriosis. And that, has to do with insulin resistance, and the GLP-1s work with that. So they're coming out with a new study because they're seeing, people who are on GLP-1s, their menstrual cycle actually, aside from weight loss, seems to come back sooner. And so if you're menstruating regular, you're ovulating, you increase your chance of pregnancy with that. And so it's kind of interesting with the insulin resistance. And I'm not a fertility doc, I'm not an OB-GYN, but it does, like with PCOS, your hormones kind of get messed up. With insulin resistance, your testosterone increases from your ovaries themselves, and your estrogen is increased from the fat cells themselves. And now you get these complicated signal pathways that are getting mixed signals. And so that's why you're not ovulating appropriately. And so again, there's another area where they're looking at, in addition to decreasing your insulin resistance with the GLP-1 and increasing your weight loss, and some of that is the GLP-1 also increasing your actual fertility, because you kind of heard about it like Ozempic babies or Mounjaro babies and stuff like that.
Thank God I'm not going to have one of those, thank goodness, at my age.
But I think it's important to note for people who are like, oh, I don't think I can have a baby, I'm not worrying about it. And then they get on these medications, like, that may change for you. So you need to be prepared. We also know that it can decrease the effectiveness of oral birth control because that's digested, right? And so you got to be careful with that.
Have you had anyone that you've treated with GLP-1s that was trying to get pregnant and actually got pregnant?
So I kind of saw them in between, but they thought that they couldn't get pregnant and they got on semaglutide, and then they did get pregnant. And then I actually hadn't seen them in that time frame. They had a successful pregnancy, and then they were coming back to me afterwards. But like, yes, they were a classic like Ozempic baby, if you will.
That's awesome. I mean, that's really exciting. I am not normally a big rah-rah, let's all take drugs kind of doctor, but I really think that so have we seen any negative side effects from being on these drugs for a long period of time? Anything that we should be worried about, looking for, like unintended consequences, or is it all just great news?
I think like with any medication that there's the possibility of side effects. I think we know the general side effects that have been out there. The nausea, vomiting, diarrhea can increase your risk of pancreatitis or gallbladder disease. There's certain people who can't take the medications, right? The medullary thyroid tumors or MEN syndrome. And there may be that when I was looking at all the cancer stuff, that's really super interesting. There was a concern that they said statistically insignificant, but maybe a correlation with like a renal carcinoma. So that is being looked at a little bit more as well. But by and large, I think these medications, their side effect profiles versus their benefits for like all these other major categories, you kind of have to weigh those back and forth. But they seem to be a pretty safe drug overall for all the different risks that they can reduce. Because we know obesity and excess weight has such an impact on so many parts of your health that this is like a great tool to help reduce all those risks.
Amazing.
Have you heard of anything that you like or like out there that you're curious about, like on the wind that people are concerned about?
Well, I'm very curious about the newer one that I don't have any experience with yet, Tide, and I don't know much about that one. I haven't actually personally investigated it. I think it's FDA approved just recently. Yes.
I have to investigate that one too. I haven't deep dived. I was kind of looking at all the other research that's come out, but it'll be interesting to see what.
I'm interested in looking into that. Maybe we can talk about that next time. I mean, neither of us has any experience with that one. Basically what's happening is all these companies are trying to work on improving the results while keeping side effects low or reducing them, or hopefully making them non-existent, right? And so the third one, so semaglutide really acts kind of in one way, and then tirzepatide acts in two different ways, and they're saying retatrutide acts in kind of more three different ways. So little tweaks to these molecules can really change the way they're having an effect in your body. So I'm really curious to see, what comes out. And I don't know. I mean, I'm very excited to have these drugs now. I mean, we just didn't have them before, and we were kind of shrugging, wondering how to get people to eat more broccoli, and that wasn't working. So I'm really excited about it still, even after all this time.
And I think that's the thing that right, is like the big deal is like, I think many people know that all these health related complications come from being overweight. But how, tell them to just go lose weight and, eat more broccoli and exercise. Like we've proven that that's just like a non-starter for a lot of people.
Yes.
And some of these people, genetically, right? Like, they're insulin resistant and they're fighting an uphill battle, and to really give another tool on the toolbox for people rather than just saying like, go lose weight, I think.
And I also think though, it does get harder as you get older. Postmenopausal, it really is difficult. So, having these tools to help people do it. I mean, I think it's been great. So anything else you want to bring up as like new in the weight loss world?
I don't know if it's new, but I feel like I always have to plug it. I think people have gotten like really focused on protein, which is so important with GLP-1s. But I think more than anything, we know that resistance training, as somebody who's like been an athlete, is just like you got to prevent it from losing muscle. And when we talk about this rebound weight gain and stuff like that too, we know that your muscle mass is your long-term fat burners. And so for people who are looking to kind of come off and maintain or go to maintenance, that I think everybody can do with some strength training and resistance training. Well, not just me. The research is out there. The votes are out. It's not debatable.
Yeah, so, agreed. I mean, ideally twice a week, lift heavy things, move your muscles. And, because we focus on protein because the drug affects people's appetite. And if you're on enough of a dose, you just aren't going to eat enough. And so you got to make sure that the little bit you are eating has enough protein in it, or you will lose muscle, whether you like it or not, and whether you're doing strength training or not. But ideally, you're building your muscles and improving them because they have a higher metabolic rate than fat. So they burn more energy than fat does. And so if you are really strong, you will have a greater reserve as you get older. You'll be able to keep it off better. And it really will help you stay strong in your old age. I mean, one of the things I'm very focused on is living your best self longer, right? So in medicine, we're always trying to extend life, but we have a tendency to just extend days of life, but not, vigorous, happy, active days of life, right? And so the more muscle mass you have, the longer you will, live a healthy life, basically. I mean, that's my direct advice.
And I always tell my patients too, like you look at your like lower legs and like lifting, and I'm like, that's your independence. That's in and out of bed. That's on and off the toilet, right? Yeah. And so we don't want to just keep living longer. We want to live longer, well, and independently. And so I'm always like, yes, we can reduce a lot of risks and things with reducing obesity, but you got to have your muscle mass so that you can live well independently. Yeah. And so that's always going to be my big plug.
And I do think that what we're seeing though is when people do lose the weight to start with, now they're more able to do the strength training and the other active things that they couldn't really do when they were more overweight. So it actually does get a little easier to do the strength training. So to try to be encouraging, it is possible. So anyway, so Randi, I really appreciate the update. I think it's been really, really interesting. And I would love to have you come back again, probably in a couple months when we have more data on the newer drugs.
Yeah, I love that. It's good to talk to you.
If you found this helpful, do me a favor and share it with a friend who's considering any aesthetic treatments. Subscribe so you don't miss the next one, and drop a comment telling me your biggest takeaway. I actually read them all. Let's keep each other safe and elevate the standards in the Medspa industry.